My name is Tonja Santos, and I'm a certified nurse midwife at Baystate Medical Center. As usual, I had to do the math before this talk. I've been a midwife for about 21 years, and 19 of those have been at Baystate. So thank you for spending this Wednesday evening on June 28th, which is actually the commemoration of the Stonewall riots, which is why we celebrate Pride in June, which is an interesting fact that you may not have known. So tonight we're going to talk about striving toward equity in maternal and infant health, which is a subject that's near and dear to my heart, having practiced as a midwife taking care of birthers in the Springfield and extended area for almost 20 years, as I said. So this work came to fruition during the pandemic, which was a really interesting time for all of us, a time that highlighted that not only is racism alive and well, but it's baked into all of the systems as we know them in our society, including healthcare. We watch headlines of police violence, the disparate impact of COVID-19, and the disgraceful differences in infant and maternal outcomes based on the color of one's skin. So what you're seeing here is a mural of Shaeja Semple, who died giving birth at Woodhull Hospital in New York in July of 2020. And in the aftermath of her death, it was discovered that her death was as a result of an anesthesia error, which was a pattern of errors and behavior at the hospital that never went corrected. So she's but one example of the very high profile and the hundreds of lower profile deaths in maternal and infant health that highlight the disparities that we see. So first, I'm going to talk to you a little bit about the why of why I do this work. As long as, here we go. Okay, so growing up, education was a priority in my house. It wasn't a priority because that's what my family had done for generations, but it was a priority because Pauline Santos grew up poor as a child of immigrants and with a family that did not place much value on the education of girls and women. So from a very young age, I remember it was just part of our family culture that learning was important and almost everything would be sacrificed for it. So this is why my mother fought to have me enrolled in a small private girls' school, breaking race and class barriers for a generation of girls who came after me. This is why when I graduated from high school, she graduated with her bachelor's that same year. This is why when I ran to my mom's office excitedly with my acceptance letter to Mount Holyoke College in my hand, she handed me back my first college sweatshirt, which she had ordered weeks before. And why the year I graduated with my bachelor's, I also watched her receive her master's a week later. In my family, we used education as a way to mitigate marginalization, our immigrant status, our lack of wealth, being Black, and in my and my mother's cases, being female. Education was not only a way to open doors, but it was also a cloak of protection. And while that education has protected me from many things, my mother never could have imagined that when I chose to become a mother, it would not protect me. As a pregnant person, I remember feeling my whole pregnancy that I was dodging bullets when my lab test came back normal, when I didn't get high blood pressure, when I got past 37 weeks and knew my baby would not be born premature, and when I gave birth to a healthy human. I am not a religious woman, but I found myself praying that the universe would help me get through this, praying that I wouldn't have eclamptic seizures, that I would not hemorrhage after birth, that I would not lose my baby. All things that were more likely for me as a Black birther in the United States. I also found myself worried about a time when I may need to advocate for myself and how it would be received. As in many places in healthcare, self-advocacy is treated differently depending on the color of your skin. If any Black birther should have felt safe in pregnancy, it should have been me, but I did not. What lived experience and data tell us is that no amount of socioeconomic, educational, or language privilege can protect Black birthers and babies from racism. It is not these things or race that is killing Black and brown birthers and babies in this country. Racism, not race, is the cause of these disparities. If we are to be judged as a society by how we care for our most vulnerable, we have so very much work to do. But the work is doable when together we acknowledge our implicit bias and racism and the impact it has on the care we provide, we can begin to move the needle. When we set our collective intellectual power to center on the margins and focus on inequities, we can make a difference. And when in every corner, we have it as our goal to make sure every patient feels heard, even when they're speaking in ways that don't fall easily on our ears, we can change lives. In this country, in every state, in every institution, in my backyard and yours, we are leaving Black and brown birthers and babies behind. It's time to build a world where being Black or brown and choosing to become pregnant does not make you feel like you have a target on your back. In the words of my forever president, Barack Obama, we are the ones we have been waiting for. We are the change that we seek. So while I don't have any disclosures of the kind that involve academic infamy or lucrative things, I do have a few things I'd like to acknowledge before we begin. First and foremost, the history of systemic racism that healthcare is also a part of. What you're looking at is the history of Africans in this country from the 1600s to now. The racism that has set the stage the last several hundred years for the racial disparities we see in healthcare today, in many areas today, is not our fault, but acknowledging it and doing what we can to combat it, its effects, is our responsibility. As we know, the US is politically, economically, and socially has many racist roots, and each system is perfectly designed to get the results that it gets. So that to me means that we need to redesign the system. At the same time, what took hundreds of years to set up will take a long time to dismantle, but will never happen unless we acknowledge and attack the true causes, which is racism and other forms of bias in healthcare and beyond. The second thing I'd like to acknowledge is that today we're focusing on anti-Black racism. This is for a few reasons. One is this is because where you'll see over and over again, this is where some of the starkest or biggest disparities exist. Some of the heaviest burden of these disparities is on Black people in this country. This does not mean, however, that there are not other equally important disparities and groups that are disproportionately impacted, like Native Americans, for example, have many, many of the same very disparate outcomes that Black people do in this country. I also firmly believe that when we address any bias and move toward health equity for any group, we will be moving closer to health equity for all. And my last acknowledgement is that this is hard, long, and tiring work, anti-racist work and anti-bias work. It affects us all differently and sometimes deeply. Just as healthcare doesn't exist in a vacuum, we as individuals do not exist in a vacuum, and we're not immune to the emotional impact that this work has. So this reflection comes from the Massachusetts Maternal Mortality Review Committee, which I sit on, which is a very important component of states understanding why maternal deaths happen in their states, and figuring out what can be done, what can be changed to decrease risk for birthers. So trauma and racial equity reflection. I recognize that discussions around trauma of maternal mortality and morbidity and racism can be difficult for many. It creates feelings of discomfort, confusion, and pain. However, open dialogue about these issues is essential to addressing them. I ask that you take care of yourselves during this talk. If you need to take a breath or take a break, please do so. But I ask you to please come back to the table because we need all of us if we are to make an impact. And finally, before we launch into the meat of this talk, I'd like to take a moment of silence because as consumers of the news and of these statistics, it's easy to disassociate with the fact that we're talking about actual lives, actual families, actual individuals, infants that don't have mothers, families that don't have a sister, a mother, a partner. So let's take a moment of silence just to acknowledge that the stats we're going to talk about actually represent people's lives and lives lost. Thank you. So in terms of an overview for this evening, we're going to talk about some data. In some places, they say no data, no problem. So it's important to understand what the data is around racial disparities. And we're going to just take a look at a small slice of those. We're going to then take a stab at understanding the causes, talking about both outdated and updated understandings. And then hopefully, we're going to outline a path forward. This is a lot of information and overwhelming information. So my hope is that if, like me, at the beginning of your journey, you felt overwhelmed, maybe helpless, maybe powerless, that you'll end this 50 minutes that we get to spend together with a sense of agency and some ideas about how to move forward. So before we talk about race and disparities based on race, we need to talk about race. So it would be irresponsible to have this conversation without contextualizing what race is and what race isn't. So what you're looking at is how race has been defined in the US according to the Census Bureau from 1790 to 2010. You're not meant to necessarily be able to read all of the teeny tiny writing. You can find this online. But I use this slide to show how the definition of race has changed over time. And as summarized by my colleague, Liza Winston, who's a midwife that I practice with, the meaning of race is constantly shifting and is being contested. We can't agree on what race is and what race isn't. There are a few things that we know, though. Its use in society has more to do with power relations, economic arrangements, social norms, and prevailing ideologies than it has to do with physical differences between and among human beings, such as skin color. Race has been used and continues to be used as a way to categorize groups of people and is often used to explain, justify, or maintain inequities and oppressive social and other practices. And while concepts of race have varied over time, often in response to resistance and struggle, thank goodness, race does remain at the center stage of US history. So what are racial disparities? Racial disparities were first described in 1985 in the Secretary's Task Force on Black and Minority Health, released by then Secretary of Health and Human Services, Margaret Heckler, and it's nicknamed the Heckler Report. So for over 30 years, we as a country have known that disparities exist. They define disparities as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups who systematically experience greater obstacles to health based on their racial or ethnic group. So now we're going to outline what some of those disparities are. And this is just going to be a very, very quick tour with some examples. So what you're looking at here is life expectancy by race and ethnicity. And you can see that the bottom line is Black non-Hispanics who have the lowest life expectancy compared to their racial and ethnic counterparts. Some of the things that underlie this morbidity or life expectancy, a good example is hypertension or high blood pressure. So here we're looking at the total for men and for women. And in each of those groups that you can see that non-Hispanic Blacks have higher rates of hypertension or high blood pressure than their counterparts. We can trace this through things like diabetes. Again, similar story for both men and women. Black non-Hispanics and American Indian Alaska Natives have the highest rates of diabetes for adults 18 and older from 2018 to 2019. And we can trace some of these trends down to the Massachusetts level as well. Just a quick look at other conditions. Obesity tells a similar story, with Black and non-Hispanic and Hispanic individuals having higher obesity rates, both as adults and as children. Asthma in Massachusetts, people who identify as two or more races, Hispanic or Latino, or Black or African American, have highest rates. And this picture is looking at the rate of cancer incidence by race and ethnicity. So the line that represents Black people, you can see that the rates for all, we're looking at colon and rectum cancer here, that all of the rates are decreasing if you're looking from 2013 to 2018. So the lines are all pointing to the left, which means decreasing. And luckily, things are decreasing for Black Americans as well, but you can see that the end point, or the lowest cancer incidence per 100,000, is higher than for all the highest rates of the other groups. So in terms of Black women, what we're looking at here is breast cancer, new cases of breast cancer. And you can see here that non-Hispanic white women actually have a higher rate of new cases of breast cancer than non-Hispanic Black women. When we look, however, at deaths related to breast cancer, we see those lines flip. And a similar story can be told with many of the gynecologic cancers. Cervical cancer, Black and Hispanic women have higher rates than white women. But then again, when we look at mortality, Black women and Hispanic women are more likely to die. Black women have the worst survival rate when it comes to ovarian cancer. In terms of endometrial cancer, the 5 Black women have the worst 5-year mortality or death rate than any other group. And this is not accountable for by the stage at which the cancer was diagnosed, which is one of the things that we often point to explain these discrepancies. Now we're going to turn our attention to maternal mortality. What you're looking at here is a global perspective on maternal mortality, or morbidity and mortality, which morbidity means getting very, very sick, and mortality means death. So globally, morbidity and mortality is decreasing for well-resourced countries. So the countries that we tend to compare ourselves to in terms of income and outcome, maternal death is decreasing around the world. This slide shows a few things. The US is in red. You can see that our rates are higher than countries that we typically compare ourselves to, and our line is going in the opposite direction, meaning that maternal mortality in the US as of 2016, and the same can be said for 2023, is higher than it's been in about 60 years. And this is a concept that I took from a midwife colleague, Diana Jawls, who does work on birth locations. So what you're looking at is Bureau of Labor statistics from 2016, listing the most dangerous jobs and the fatal injury rate or deaths in those jobs. And if we place becoming a Black mother amongst these highest risk, most dangerous jobs, it's pretty sobering. So for Black women in the US, they are 4 times more likely to die in pregnancy than their white counterparts. Black birthers make up about 14% of the US population, but account for 30% of maternal deaths in this country. These rates are on the rise, and the biggest increase is for Black women. The other thing that's important to understand is that maternal mortality or maternal death is an important metric to follow, but also we know that for every death, there are many, up to 50 instances of near misses, or what we call severe maternal morbidity, SMM. And with severe maternal morbidity, Black women are also bearing more than their fair share of that increase. In terms of Black infants, there are higher rates of preterm birth for Black infants. So here we're looking at preterm births in various gestational ages. So no matter which gestational age range we look at, 34 to 36, 32 to 33, or less than 32 weeks, Black women have higher rates of preterm birth. This is from 2014, which is almost 10 years ago, but the trends are the same. In terms of infant mortality, the good news is that infant mortality is on the decrease for all racial and ethnic groups. But we see, again, it's very, very clear that infant mortality, which is infant deaths up to 1 year of life, are much higher for Black non-Hispanic women. And this is one of the places where I think it's helpful to try and make these numbers actually meaningful to us. So there was one study in Florida where they looked at 1.8 million hospital births in Florida between 1992 and 2015, and they described it in this way. If the mortality rate for Black babies were the same as it were for white babies, 2,800 fewer babies would die annually. And it would be nice to say that that's what's happening out there in the world, but here in Massachusetts, we're so progressive, and with universal health insurance, things are different, but the trends are the same. So maternal mortality in the state of Massachusetts for all women, you can see here, is 5.6. For non-Hispanic Black women, it is 17, or about 4 times that of non-Hispanic white women. Preterm births tell a similar story. The risk for Black women is higher than that of white women. And infant mortality, or the rates of infants dying, is about double that of white women in the state of Massachusetts. And these statistics are from 2005 to 2014. And thanks to the Springfield Health Equity Report, we have Springfield level data, which tells, again, a similar story. So infant mortality in Massachusetts is 4.5 per 1,000 live births. It's higher in the city of Springfield. And then when we break that down, Black women are about 3 times more likely than their Latina or white counterparts to have their infants die. And underscored by a similar story, and much of what contributes to these infant deaths: low birth weight and preterm birth, both of which are higher for Black women in the city of Springfield. So why do these disparities exist? It's something that I've pondered quite a bit. And it's mostly a story of yes and. So we know that it's not entirely explainable by poverty. We do know that because of institutional sexism and racism, women are more likely to live in poverty, and Black women more likely still. But numerous studies controlling for education and socioeconomic factors find that Black women remain at higher risk of maternal and infant mortality, despite income level. So is it access to care? That's another explanation people try to propose for these disparities. We know that Black women have lower percent of access to prenatal care than non-Hispanic white women, but they tend to have better access to care than Hispanic women, yet Black women have the highest maternal and infant mortality rates. And one study showed that African-American women who initiated prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. And what about other social determinants of health, things such as obesity or smoking that we know impact people's health? So are those the things that are impacting and creating these disparate outcomes? Study after study has looked at these things and ruled them out as a driving factor for these disparities. One study in New York City looked at, showed that African-American women with normal weight were still at higher risk of dying in the perinatal or around pregnancy period than non-African-American obese women. A related study looking at infant mortality showed that obese Black women and non-Hispanic white mothers showed that non-Hispanic white mothers had uniformly lower risk for infants dying. And what about education? We know that education is also an area where systemically racism has a huge impact. Black women are less likely than white women to have a high school education, but education does not eliminate disparities, and it's not as protective for Black women as it is for other racial and ethnic groups. So you can look at studies and they, for example, of white women, and as white women get more educated, their risk of dying in pregnancy and their risk of their infant dying goes down. The same cannot be said for Black women. One study looked at pregnancy-related mortality ratio. Black women with a less than high school education fared better than Black women with a high school education, with some college education, and college graduates. In terms of infant mortality, college-educated Black women have the same risk as white women with a less than high school education. So education also does not explain these disparities. So these are the traditional explanations that the healthcare world has used to try to explain these disparities: poverty, access to healthcare, social determinants of health, and education. But study after study are showing us that even when you control for these factors, these disparities exist. This leads us with the reality that racism, not race, is killing Black women and babies in this country. Professional organization after professional organization have come out with statements over the last 2 to 3 years pointing to racism as a risk factor for people's health, including then Attorney General Maura Healey, now Governor Maura Healey's call to action, building toward racial justice and equity and health. So how is it that racism impacts health? So this is a very complicated schematic. We could spend hours and hours and hours and college courses and dissertations talking about this, but we don't have time for that this evening. So I'm going to give us some areas of focus. So we've already talked about mortality, which is death. We've talked about morbidity, which is getting very sick. And between those two things is severe maternal mortality, severe maternal morbidity, actually, which is a very important metric to follow. So we want to be paying attention to those instances where the near misses. Those are important too. So we know that racist science and medicine have contributed to the ideas, to the myths that we have about Black bodies. That's contributed to the institutional and systemic racism that we see in all of these areas: housing, education, the environment, employment, healthcare, violence, politics. I could go on and on, but the box was only so big. We know that that directly leads to suboptimal care. So think about people who have their healthcare limited, their choices limited in location by where they've been limited to be able to live, and therefore their limitations around where they can seek healthcare. We also know that there's individual racism out there, and these forms of institutional and systemic racism contribute to what's called allostatic load, also talked about as weathering. So this is an important concept, and for me goes a long way to understanding why it is racism, not race, but it can sometimes look like race. So all of these forces create what's called allostatic load, which means that as the body is continually subjected to stressful stimuli, the place of allostasis, or the resting place of the body's systems, is changed, is elevated. And that contributes to an increased likelihood to get sick. Related to allostatic load is epigenetics. So epigenetics looks at allostatic load, but how it impacts one generation to the next. So these things, allostatic load and epigenetics, contribute directly toward morbidity or sickness. But the other thing, many of these things that I've talked about, we have limited ability to impact. If you think about your day-to-day life and going from home to school or to work or to drop your kids at school, we have pretty limited ability on a daily basis to impact all of these things. But the one thing that we do have under our more immediate locus of control and our purview is individual racism and unconscious bias. So we're going to spend some time talking about that, because I think addressing those things are absolutely essential to improving the disparities that we see in healthcare. So what is unconscious bias? So in a book called Blind Spot, they make an analogy, a comparison between the blind spot in the retina and blind spots in our mind. So in this exercise, and it's actually a really good book, I'd recommend that you go get it. It's great as an audiobook, but you won't get to see all of the pictures in it. In this exercise, if you cover one eye and look at the plus sign and move your face closer to the screen, the black circle will disappear. So this demonstrates that there is a literal blind spot in our retina. If you do this exercise, and these second two exercises are to show you what the mind does, what the brain does when it encounters a blind spot. So if you cover your right eye, focus on the plus sign, move your face closer to the screen, the black dot disappears, and what your brain perceives is a solid rectangle of yellow. So the brain, without you even asking it to, replaces this missing information with information that it thinks makes sense. The rectangle is yellow, so that missing bit of data is probably yellow. Just makes sense. And then in this third exercise, the yellow circle will be replaced by a red circle. So the mind is like the retina and makes similar adjustments without us even asking it to help us understand the world around us. So we have areas of missing information in our brain, just like the retina. And when we encounter these missing pieces of information, our brain will pull from other sources of information to fill in that information. And it will go even further to kick out a piece of objective information, which is there is a yellow circle in a sea of red circles, and make it look to our brain like they're all red circles. So our brains do this quickly without notifying us that there's missing information. It makes these adjustments, these deductions, these assumptions. And our brain is built to work this way. It's an important skill set. Excuse me. It was an important survival skill set when we lived in clans, and people who looked like you were safe. People who looked like you, talked like you, were likely a part of your clan, and they were more likely to be safe than people who didn't look like you and didn't talk like you. So unconscious bias and the filling in of this information is a maladaptation that our brains have to the way we live now, which is we live in diverse environments for the most part. Within a day, you can be halfway around the world and surrounded by people who look nothing like you. This is not a personality flaw. This is how our brains have been constructed to work. None of us are immune from this phenomenon, and our challenge is to, without blame, with humility and compassion for ourselves and for one another, acknowledge that this process happens, that we have implicit biases, and figure out how to combat them. So hopefully, we've talked about what disparities exist, and there's no denying that disparities exist. Hopefully, I've made a compelling argument that we all have unconscious bias, and that it's not a character flaw or because we're bad people, but because the way our brains work. But I think it can be hard to make the connection between implicit bias and negative outcomes in healthcare. How does that actually play out? So here's how it plays out. So we have these implicit biases that we know exist or don't know exist. Hopefully, toward the end of this talk, you'll be moving toward figuring out what some of your implicit biases are if you haven't thought about this before. In healthcare, these implicit biases have shown to lead to a couple of things: differences in perception of patient presentation and differences in perception of clinical presentation. So patient presentation, situations where patients are thought of as non-compliant, angry, violent, rather than upset, disagreeing with the recommended treatment plan. Then we add that to differences in perception of clinical presentation. And we'll talk about this a little bit more later, but there are several persistent myths out there about Black bodies. If you believe that people feel pain differently, for example, you are going to interpret someone presenting to you clinically with pain differently based on the color of their skin if you hold that implicit bias that you either know about or don't know about. So add those differences together, and what we get is differences in how patients are treated, both treated in what's called the affective domain, so the interpersonal domain, less time spent talking to patients, dominion of the provider over the conversation, less patient-centered care, less warm and friendly care, less team-oriented care, and poor communication. And I don't know about you, but that is not a recipe for care that I necessarily want to go back for. Also leads to differences in treatment in the clinical realm. And we'll talk about this again, less diagnostic testing. If you believe that Black people feel pain differently and a Black person comes to you with reports of pain, they may not get an X-ray, where someone else who you believe presents or feels pain differently might get an X-ray. So less diagnostic testing, undertreated pain, less guideline concordant care, we'll get back to that, and fewer referrals. So these in turn lead us to a couple of places: differences in patient satisfaction, which in turn impacts willingness to seek treatment, adherence to recommendations, and follow-up care. Like I said, that list in the affective domain is not a recipe for care that I want to come back for. And it also directly leads to poor clinical outcomes and disparities in health. So that person who didn't get an X-ray probably didn't get the broken bone or fracture diagnosed. and didn't get the appropriate treatment, whereas someone else may have. So we know that bias and racism and medicine exist. Some of the places where it's the best studied are emergency department studies. Study after study show that in emergency rooms, there are often longer wait times for Black and Brown people. Lower triage scores, or basically how quickly does this person need to get seen scores for people with similar conditions based on the color of their skin, and lower odds of having radiologic testing. The other area that this has been really well studied is in pain management. Study after study shows that from primary care to cancer treatment to the emergency room, Black people are less likely to receive adequate pain control in and upon discharge from the ED. They're less likely to have pain control for the same conditions and things that are very objectively painful, like a broken leg. And they're less likely to have pain well assessed and controlled. PP means postpartum, in the postpartum period. One study looked at false beliefs about Black bodies within the lay public and within medical trainees, just because that's the group that they were studying. And what they found was fascinating. They found that the more negative beliefs that the medical trainees had about Black bodies, the more likely they were to undertreat someone's pain. And that's whether or not the false beliefs related directly to pain control or pain tolerance. And furthermore, things that increase this bias included overcrowding and high volume, which we know are common in emergency rooms and common in healthcare settings. So we also know that racism is alive and well from lived experiences. So this is from an article in the New York Times in December 23, 2020. So Dr. Susan Moore was admitted after testing positive for COVID in suburban Indianapolis. She said that she had to beg the physician treating her to give her antiretrovirals. When she reported pain, she was told that he couldn't justify giving her narcotics and intimated she would be sent home. She said, "I was crushed. He made me feel like a drug addict." When she reported shortness of breath, the doctor denied it and eventually ordered studies. She then got more pain meds, but waited hours to be dosed. She said, "I put forth and I maintain that if I was white, I wouldn't have had to go through that." She was discharged home. And when several calls went unanswered, the hospital sent an ambulance. When they arrived, she could barely walk and was breathing heavily. She was readmitted within 12 hours of being discharged to another hospital, had bacterial pneumonia, was placed on a ventilator, and died shortly after her second admission. This is but one example of people's lived experience that demonstrates that bias is alive and well all of our institutions and areas of life, including healthcare. So, where do we go from here? I presented you with a lot of information, which is very easy to become overwhelmed with. So where do we go from here? We make a start. We don't need to be experts, but no one is going to do this for us. When I began this work back in 2020, I began it with the feeling that I didn't have all the answers, but if we didn't start asking the questions, we would never have the answers. Since we've acknowledged and tracked disparities, they've existed. The centuries of racism that have gotten us to this place. And only by asking the questions and acknowledging our racism and bias and pushing through them, working through them, are we going to see change. Anthropologist Margaret Mead said, "Never doubt that a small group of thoughtful, committed people can change the world. Indeed, it's the only thing that ever has. And we are that thoughtful, committed group of people. So next, we're going to turn our attention to addressing implicit bias in disparate outcomes at the institutional level. And then we'll talk about what we can do as individuals. And then finally, some advice for Black and Brown birthers. So at Baystate, we have taken a three-pillared approach. In 2020, with the support of the department, I established a Racial Disparities and Health Equity Committee. And the work that we do looks at the clinical, the structural, systemic, and the cultural. And we're going to talk a little bit about each of those. So in terms of clinical, data is a huge, huge hurdle that many institutions have to overcome. Not only do we have to know data, have data on, for example, what are our C-section rates, what are our postpartum hemorrhage rates, but having that data stratified by race and ethnicity can be very challenging. So we've made many, many strides at Baystate and now have this data, including patient satisfaction data, which is very important, stratified by race and ethnicity, and hope to only expand that and also expand it to language and sexual orientation, gender identity. So then we also have some interventions that address this part of the cascade in the affective domain, such as doulas, which are labor support people that that have been shown to improve outcomes for Black and Brown birthers. And I believe they impact them through this affective domain with time spent, patient-centered care, and a team-oriented approach and enhancing communication, as well as things like Baby Scripts, which is a mobile app for monitoring blood pressure, which has greatly expanded our ability to monitor blood pressures in people's homes or wherever they are by taking their blood pressure on a cuff that automatically gets uploaded to an app. We've also done work on things in the clinical domain. So one of the biggest things that we've done is working with or instituting evidence-based guidelines in the areas that we know there are disparities. So for example, hypertension disorders or high blood pressure in pregnancy, cesarean section rates. And I'm going to use postpartum hemorrhage as an example. So in the department over the last several years, we have developed an evidence-based tool based on evidence-based guidelines on who is most at risk for postpartum hemorrhage. So when someone is admitted, they get a risk assessment based on their history and clinical characteristics. We revisit this risk assessment as the clinical situation evolves. And then we have preparations in place, which are prescribed and written out based on someone's risk assessment. So it takes some of the subjectivity out of some of these very high stakes, very high risk areas of risk for people. So the second pillar is systemic and structural change. So many of you are probably familiar with this infographic. This is what equality looks like. Each of these people is trying to access the resource, which is the game, and they have equality, which means that everybody has the same size box. The problem with equality is that it assumes people are starting from the same place, which we know is not the case. So then we turn our attention to equity. We give people the tools that they need to access the resource, which is the game. So that may mean that someone needs 3 boxes while another person needs 1. That's what equity looks like. I would like to challenge us always to think about justice and removing the actual barrier. There are many times when the actual barrier can't be removed, or certainly in the short term, it can't be removed. So what we're striving for is equity. But whenever we can, we should be looking and striving toward justice, not equity, where the actual barrier itself is removed. Before the pandemic, if you asked me if we could provide any prenatal care safely by telehealth, I would have said no way. But the pandemic forced us and showed us that in some circumstances, in some limited ways, there are some parts of that care that we could provide remotely, which decreased the barrier, which was showing up, which is the ride, which is getting childcare for many people. So structurally, again, looking at the data, as I talked about, looking at feedback and ways that patients can give us feedback, including at Baystate, we have something called a safety response system, which is the institution's way of being able to giving employees the ability to report incidents in the institution with an eye toward improvement, not in a punitive way. There is now an option to choose for dignity, insult to dignity, on the part of an employee who witnesses an interaction, and that is a reportable event. Also important are quality processes in the areas where we review our patient outcomes to see where we could have done better or may have done things differently. We ask ourselves the question, did implicit bias potentially play a role here? Meaningful inclusion. So having people at the table who are impacted by the decisions that you're making, and how do we make that happen in a meaningful way? And finally, checklists for decisions. We use checklists for decisions all over the place. When you get into the car, you don't really think about it this way, but you probably go through a checklist. Do I have my seatbelt on? Can I see in the rear view mirror? Am I free from distractions? Did I turn my phone to silent? We know that checklists help decrease subjectivity and make things generally safer. So this is an example of a checklist that we use in the Department of OB-GYN for making decisions and looking at and assessing guidelines. And finally, but certainly not least, cultural change. I perhaps save it for last because it's the most difficult, I think, to make happen. At Baystate, we've undergone, almost the entire department has undergone cultural humility training. We have ongoing trainings on things such as trans-inclusive spaces, immigration, trauma-informed care, trying to always have ways to go deeper and exploring how we can create safer environments for the people we care for. We talked about inclusion of assessment of the potential role of bias in our clinical care, and then engaging in our individual work. The department has been very strong in our recommendation and support of individuals within the department doing their own individual work around their implicit bias and racism. And I think I'm gonna forward through very quickly a little bit of this information on implicit bias, but I'll hit a few points. So in order to address your implicit biases, you need to know what they are. What happens when we start to look at our implicit biases? I think a lot of people have to go through a grieving process because oftentimes our implicit biases don't match our explicit biases. And I think people go through a natural process of denial, shame, powerlessness, and acceptance. And our goal is to know what our biases are and get toward acceptance so that we can start to mitigate them. One way to do that is with implicit association tests, or IATs. They can be found online. These are free tests that you do in the privacy of your own home that can help you to uncover some of your implicit biases. Another way to do that is by expanding your horizons and perspective taking. Understand, read, take other people's perspectives, broaden your horizons. We will skip past this. So the parts that I think that we can combat, where we can combat combat implicit bias the most is with the application and the activation of these biases. So we know these biases exist. Hopefully we'll do a little bit of work to figure out what they are so that we can combat them. But then what do we do to combat them? So we know that some things make the activation and application of biases worse. High workload, fatigue, uncertainty, because your brain, when it reaches something uncertain, tries to fill in information to complete the picture. Time pressure. So these are some of the things that make implicit bias worse. Things that make it better: awareness of your biases. So it has been found that when you contemplate your biases before interactions in instances where they are likely to be activated, you are less likely to act on them. Individuating or making a concerted effort to focus on specific information about the individual makes that information more important in any decision making than information that you're going to fill in by yourself that might be erroneous. Perspective taking, which means making a conscious effort to see the situation from the individual's point of view. So in interaction to interaction, or in general, seeking a variety of sources of information, like the books that I showed you earlier. And then finally, slowing down. We know that slowing down decreases the likelihood that bias will be activated. Once it's activated, it can increase our awareness of the bias so that we can use self-regulation strategies. Slowing down or mindfulness reduces the stress that promotes activation, and it can engender empathy and compassion. So for providers and for all of us, I encourage us strongly to engage in the personal work, then to pull together a working group. And I define working group loosely. For me, it was my colleagues in the Department of OB-GYN. For you, it may be the teachers that you work with, or your friend group, or another social group that you're involved in. And you don't need all of the answers, but start to look at the systems and the environment around you. For us, clinically; for other people, outcomes. Systemically and structurally, what are the structures surrounding you that may be unintentionally supporting racist or biased policies or outcomes? And then culturally. And then create a vision for where you want to be and what you want things to look like, and then just begin. You don't need to have all the answers, but you need to begin. For Black and Brown consumers, I encourage you, not that this is your work to do, this is the work of the healthcare field to do and the system to do, but find your safe place. Find providers who will listen to you, partner with you, understand your unique risks, and use those evidence-based protocols, but contextualize them within your life. Advocate for yourself via a birth plan, finding advocates like doulas, communicating clearly. If you don't feel like you're being heard, then say that much. Knowing the warning signs and listening to your body. Giving feedback and participating in change when you can. This is a tall order. If you are a Black or Brown person and in a healthcare system where you don't feel safe, then it may not feel safe to you to participate in that way. But when you can, we certainly need the feedback and need your wisdom. And then finally, find your joy. Pregnancy, for many people who have chosen to be pregnant or chosen to continue pregnancies, is a time of excitement and expecting. And there are some challenges, of course, even if it's a planned and happy pregnancy, some challenges involved, but try to find the joy in your journey. And a lot of that can be through support. So poet Maya Angelou said, do the best do the best you can until you know better. Then when you know better, do better. At this point, we know better, and it's time to do better. And what do we want future generations? How do we want them to interpret our slice of this pie? What's it going to look like? And is it going to look different from the slice before it? So my vision for us is that we can use the word racism and racist again as descriptors of thought patterns and behaviors, not as an insult, that we can use those words respectfully and compassionately to do the work and get better. That we center people's voices and treat every incident where someone feels their dignity has been compromised as a serious event. And for these girls and Black and brown women and girls everywhere, I want them to have faith that they'll be in safe as pregnancy as anyone, that they'll be given all the choices, all the options, all the guideline concordant care, that they'll feel seen and that they'll feel heard and that they'll feel safe. It's time to stop leaving women and babies behind. We can do better, we must do better, and we will do better. We won't get there overnight, or not even over a decade, but we're certainly not going to get there by ignoring implicit bias and racism. What's yours? So with that, my many thanks to the people who have supported me through this work, my practice, the Department of OB-GYN and Midwifery leadership, the Racial Disparities and Health Equity Committee, who have been coming together month after month during their evening times, even when the weather's nice, to keep pushing this agenda forward. Baystate Medical Center for being such an open environment to do this work in, and for you for deciding to spend an hour or an hour and 3 minutes of your Wednesday evening this way.
Great work, Tonja. Boy, I applaud you. That was a great presentation. We do invite those that have attended to type your questions in the Q&A box. And I see one there already, Tonja, if you want to take a look at it. And if, in fact, you want to see this presentation, you can check baystatehealth.org and youtube.com/BayStateHealth in a couple of weeks, and we'll have the recording there.
So there is a question in the chat: as a recipient of possible biased care, how in the moment do we get noticed and we receive what is needed? That's a challenging question. Because, as I said, it can be a very vulnerable position depending on what your medical need is at the time, to challenge your healthcare providers. My hope would be that there may be an ally somewhere around you who can call out the behavior, or at least stop the behavior or intervene as it's happening. If not, and if you have the wherewithal, I think saying, I don't think you're hearing me. I'm telling you X, Y, or Z, and I don't feel heard. I think communicating what your concerns are very concretely. I'm concerned that you're going to miss something that's very dangerous or very wrong with me because you're not listening to me and my concerns. I guess that's how I think ideally the situation could be approached. And if that doesn't work, I think it's reasonable to ask for someone else to be brought into your care or involved in your care who you do feel like is able to listen to you. And I hope that answers that. Honestly, the responsibility should not be on the individual. The responsibility should be on the institution, and that's where we're trying to place it.
Well, thank you for that. And that's an excellent point as well. We'll just give the attendees just another minute in case they have a question. But what a great presentation. And I like the fact that you ended it with actionable things that the different groups can do. I thought that was really terrific.
Yeah, I think that's one of the biggest challenges is we all know there's a problem. But what do we do? Where do we go from here? What's the next step? So I think it's important to make pieces of it accessible to making change. And since so much of it lies with the individual and with our implicit bias, it's an easy topic to suggest change.
Well, I think we're at time, but I want to say thank you again for that brilliant talk, and I applaud your efforts. Thank you so much.
Thank you so much for having me. Appreciate it. Have a good evening, everyone.